Good evening, everyone, and welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LiUNA, the Laborers International Union of North America. My name is Leslie Rattan, and I'm pleased to be moderating our series on concussion, and it was developed for people with persisting symptoms of concussion, their caregivers, and healthcare providers. If you've been here before, you know that sessions focus on various aspects of concussion, include, we start off with an expert speaker, and that goes for about the first half from till about 6:30-ish or so. And then for the second half, we open it up to questions and answers. And just so you know, the sessions are running every other Tuesday, on Tuesday evenings from 6 to 7 p.m. So tonight is our 22nd session. If you've missed any of the previous ones, you can go to the Canadian Concussion Center's website, and all of the previous webinars are recorded and archived there. So you're able to go in and watch them if you like. For this evening, if you have any questions, we would ask you, if you look down, if you scroll down, you'll see a Q&A on the bottom right-hand side of your screen. So if you have a question, just enter it there. If you're having any technical difficulties, please just enter those into the chat and somebody will get back to you. So for this evening's session, I'm really pleased to announce that we've got Josie Tome with us, and she's going to be talking about navigating insurance systems. And we are also going to have Dr. Carmela Tartaglia join us, who's a neurologist, works with individuals with post-concussive symptoms at the Toronto Western Hospital. So she's going to join in for the question and answer period. Josie is a physiotherapist by background with over 20 years of experience in the areas of brain and complex trauma injury assessment and treatment within the complex injury outpatient rehab program at Altum Health, which is located at UHN, or the University Health Network. She's currently a senior manager of program quality and outcomes at Altum Health, with oversight of the WSIB neurology and mental health specialty programs and other third-party payer programs across the organization. So with that, I'm going to turn it over to Josie.
Thank you, Leslie, and thank you to the Canadian Concussion Centre for inviting me to this webinar series. I'm happy to be co-presenting with Dr. Tartaglia this evening. I'll take you through a short presentation on navigating the insurance systems. I'm not an expert, but I do have a lot of experience in some of these systems. Next slide, please. So my hope this evening is to provide a high-level overview of the WSIB programs, the MVA insurance system, discuss some barriers that individuals may come up against when trying to access treatment services, and a little bit about us, Altum Health, and then over to the audience for questions and discussion. Next slide, please. Okay, so this is a slide from WSIB, and it's meant to demonstrate WSIB's continuum of care and programs for someone who's been diagnosed with a concussion or a traumatic brain injury. It's a little bit busy, but we'll focus on one area at a time for each of the streams. If you look to the middle of the slide, you will see 3 circles intersecting. WSIB has 3 streams of care, and someone can access them at different points in their recovery. So I'm going to go through each of them in my upcoming slides, but as an overview, on the left-hand side of the screen in green, WSIB has programs of care within the community. So individuals with concussions could access these immediately for their treatment. At the top of the screen, you'll see the Occupational Health Assessment Program, which is an assessment-only stream of WSIBs. On the right, in the dark blue, you will see the WSIB Neurology Specialty Program, and this is typically accessed further in recovery or for more significant injuries. It's a much more comprehensive assessment program, and it also has treatment options available. And we'll see the screen again. Next slide, please. Okay. So the WSIB MTBI program of care. So this is a program that individuals with concussions and mild traumatic brain injuries can enter into early and for up to 3 months after the date of their injury. Providers in this stream need to be registered with WSIB. If you go to the WSIB website, you'll see a list of those providers that have been registered to deliver this program. They're regulated health professionals, for example, physiotherapists, occupational therapists, chiropractors, and they have to have the scope of practice, knowledge, and skill to deliver the MTBI program of care. And there's also some training provided to these professionals. It's about an 8-week program, and it consists of 2 4-week blocks that are pre-approved by WSIB. And usually individuals attend once weekly, and the intervention is typically done by single discipline. The clinics are expected to provide evidence-based interventions, which includes education, gradual integration of activity, progressive exercise therapy. Some individuals may require manual therapy and/or vestibular rehabilitation. And after you're done that 8-week block, WSIB can approve additional treatment for another 4 weeks. Next slide, please. Okay, continuing with the WSIB MTBI program of care. So the requirements to access this stream, individuals have to have an allowed WSIB claim. They have been diagnosed with a concussion, an MTBI by a physician or a nurse practitioner, and they have negative findings on neuroimaging studies if they had those completed. So as I described, WSIB has a neurology specialty program that individuals with more significant injuries would be referred into. They have to be 18 years of age or older, and again, it's within the first 3 months from their date of injury. Next slide. Okay, so here's the diagram again. We're going to move to the turquoise blue, the OHAP stream for MTBI, which is like a conduit between the community programs and the more specialized program. Next slide, please. So the OHAP assessment is initiated by WSIB. And the reason they might initiate this type of assessment is WSIB might be looking for an opinion and/or a response from a physician to a specific question that their team has. They may be looking for clarification or an opinion on compatibility for entitlement, treatment, or medication recommendations, or they feel a peer-to-peer conversation with the OHAP MD and the primary health professional or the GP is needed to help support the individual through their recovery and return to work. Next slide, please. So the OHAP assessment takes place with a physician who's trained in mild traumatic brain injury and also with a clinician. From the OHAP assessment, once it's completed, there are 3 pathways. So 1, they could recommend further treatment in the community, or perhaps there's some medications that need to be trialed for various symptoms. 2, no further intervention is required. The patient can be discharged with the home program and possibly a return to work plan. And number 3, individuals who are not progressing with their recovery can be referred to the WSIB neurology specialty program for assessment or go directly into treatment from OHAP. Next slide, please. Okay, so now we're going to talk a little bit about the right-hand side of the screen, which is the neurology specialty program. Next slide, please. Okay, so this assessment is also initiated by WSIB. It's a very comprehensive assessment with a physician specialist and a clinician. For example, OT, physiotherapy, and kinesiology can all be involved in the assessment. The team will do a thorough assessment of the physical and cognitive functioning of an individual. It requires communication with the worker's primary health practitioner or GP after the assessment. There's also a call to the WSIB team. If there's a return to work specialist on file, then there is an expectation for that team to connect with the return to work specialist. So within this program, there's access to specialized diagnostics and consultations. For example, the initial assessing MD might say, you need to see a neurologist on our team, a physiatrist, an ear, nose, and throat doctor, a neurooptometrist. You may be referred for psychiatry, psychology, sleep lab assessment, dental clinic assessment, or EMG. I'm sure there's more, but that's just to name a few. Next slide, please. So typically this program is access for individuals who are further along, typically greater than 4 months or later from the date of injury, or they may have signs and symptoms of more moderate to severe brain injuries, or they may have ongoing persistent symptoms affecting their function and their ability to return to work, or they've had insufficient response to the treatment that they've already received, or they may be experiencing significant psychosocial issues affecting typical recovery, or if coordinated interdisciplinary care or treatment is required. These are some of the reasons that would be triggered for referral into that specialty program. Next slide, please. Okay, so for the treatment services under this umbrella, treatment in the specialty program can be multidisciplinary, and it usually is. For the comprehensive treatment program, individuals can attend 2 to 4 days per week, up to 4 hours per day, and it's typically an 8-week program. There's a focus on return to pre-injury activity and support from the team to facilitate return to work when it's appropriate. So the core components of the program, individuals will meet with each of the allied health professionals for treatment, physiotherapy, occupational therapy, kinesiology. They'll also have access to psychology or psychotherapy services. They'll receive a lot of education on concussion or MTBI and recovery and symptom management. Work simulation programs are a component of this treatment stream, and there's also a reactivation component. Next slide, please. Okay, so now we're going to move our attention to the MVA world. So an injured person can access assessment and treatment if injured in a motor vehicle accident, MVA, through 3 categories. There's the minor injury guideline, the MIG, and it's really for sprains and strains types of injuries. There's pre-approval for assessment and treatment funding up to $3,500, and there are some insurance forms, and they're referred to as the OCF 23. They can also access care through the non-MIG, non-minor injury guideline arm, and it's meant for more significant injuries. So there are different insurance forms, which are called the OCF 18s. They're submitted by your healthcare worker to the auto insurer for auto insurer to approve it. Individuals will have a larger sum of money for the rehabilitation needs, approximately $65,000, but it also encompasses other aspects of the care that they require. And then there's also a catastrophic injury category, and these individuals will again have a much greater amount of funding available to them for their rehabilitation need and also their attending care needs. So in this MVA system, the Financial Services Commission of Ontario, which is called FSCO, sets out the rules and regulations of claims managed through MVA insurers. And there's lots of information on the website with resources that you could look into. Next slide, please. Okay, so access to service, and sometimes we see denials or barriers to receiving approval for services. Some of the reasons could be there's an unclear diagnosis at the time of initial injury. It could be that there's sparse medical documentation of the initial injury. For example, we've seen ER notes, emergency department notes, that maybe only make a note of headache and neck strain and don't actually diagnose a concussion or an MTBI. Or they may be more focused on more significant complaints, for example, if there's a fracture, versus all of the injuries that were sustained during the motor vehicle accident. There could also be sparse information in the required insurance forms, for example, the OCFs, that the healthcare practitioner should be completing more fulsomely. And funding within the category of the injury has been exhausted. We hear that a lot, and the adjuster might deem the injury minor and keep that individual in the minor injury guideline category. Next slide, please. Okay, some suggestions or helpful hints to get those treatment plans approved. So individuals should have a thorough examination by the GP or specialist detailing symptoms, the diagnosis clearly, and all the treatment recommendations that will help with this individual recover. The clinic or the clinician where care is provided should have experience in concussion or MTBI assessment and treatment. With this experience, they'll be able to provide the necessary rationale for the evidence-based treatment and expected goals and the outcomes of treatment. There should be detailed information going to the insurer in the required documentation, for example, in the OCF and also in the formal reports. And the healthcare worker or clinic should use outcome measures to demonstrate meaningful change and support the treatment plan. Communication by the clinic with the adjuster is always helpful. Sometimes they just need education on the diagnosis or anticipated recovery. They just want to hear the plan from the healthcare worker. And sometimes the adjuster will request an independent medical examination with the hopes of gathering more fulsome information. And next slide. Okay, so a little bit about Altum Health and who we are. So Altum Health has been around for years. We've been providing assessment and treatment for clients with concussions, all the way to severe brain injuries, as well as other musculoskeletal injuries. We're able, and we do provide all levels of care through WSIB program of care, through that occupational health assessment program, and that very specialized neurology specialty program. And we also have the complex injury outpatient rehab program, which is CIOR, which originally was housed at Toronto Rehab for several years, but we've moved over to the Altum Health organization. It's a specialized rehabilitation arm for clients involved in MVA or who are accessing other insurance systems. So we have a full multidisciplinary assessment and treatment team, and that's our approach. And it consists of physicians, specialists, physiotherapy, occupational therapy, kinesiology. We have chiropractors, speech language pathologists, psychologists, and psychotherapists. Our treatment plans are individualized based on the specific needs of the patient, and we're committed to helping every client return to their pre-injury life. That's the goal. Next slide, please. So if you're looking for information on Altum Health Services, we have 12 locations that you see on the screen: west, north, central, and east. You could visit us at altumhealth.com. And if your health practitioner or yourselves are interested in making a referral to the program, there's the link there, the address that you could use. And next slide. Final slide, and that's just a big thank you for having me and for listening to the presentation. And I think Carmela, Dr. Tartaglia is going to join us now.
Still muted. Hello.
Great. Carmela, were you going to say anything before we jumped into the questions?
No,
No?
I think, I think we wanted this session to really be about navigating this system, which a lot of my patients have told me is not easy. So we're happy to answer questions as best as we can.
Great, thank you. Well, we've already got a few questions in. So let's see. Okay. First question, why is my neurologist's referral for a specific treatment not sufficient for approval? I informed my insurance adjuster that my neurologist had referred me to a private vestibular therapist. I was told this type of therapy is okay as long as it's within the MVA OCF 18 system, but I must contact the neuropsychologist who did the independent assessment to see if they agree. And if so, that doctor needs to send a referral. Please comment.
That's an interesting scenario.
Yes.
So it seems an IME took place with a neuropsychologist who would be commenting on the psychological status of the patient and what that patient needs from a mental health treatment or from that psychosocial support, but probably wouldn't be addressing specific physical therapies, for example, vestibular rehabilitation. And we find with a lot of these folks, there are complaints of dizziness and imbalance after a concussion or an MTBI. And if appropriate, vestibular rehabilitation is a part of the rehab that they should receive.
Great, thank you. Maria, since the client has paid for MVA insurance for decades, why does the insurance company get to deny treatments that are recommended by medical professionals? Why not give the budget to the TBI patient family for spending?
All I could do is agree.
Yeah.
So, I mean, adjusters are going to adjudicate the claim the way they feel it should be adjudicated. If there's strong rationale from those healthcare workers that explains the reason to provide the therapy or the reason for the extension or what goals will be accomplished within that particular treatment and the purpose of it to return the person to function and possibly, avocational activities or work activities. If it's clearly outlined in the information the adjuster receives, I don't know how to, what else to say about that.
Okay, thank you. We have another question. I'm just looking to the chat. What is the rehab amount provided in a catastrophic injury?
It's up to $1 million, but there's also like attendant care that falls in there and other benefits as well. And I don't know specifically right now which one of those are teased out, but I know the amount is 1 million for their med rehab needs.
Right. And I think if I'm not incorrect, that it's a really good idea for people to check their auto insurance policies to ensure that they've actually checked that additional benefit, because the actual cost for it, I think, is quite low. Is that right, Josie?
Yeah, that's what I've heard as well.
Okay.
So in speaking with lawyers, they'll tell you that they have done that. They make sure their policies that they have the right coverage, and they really suggest to everybody have a close look at your coverage plan to see if that's in fact going to meet your needs should something happen.
Yeah. Okay. If the ER doctor neglects to document a head trauma or TBI, what is one's recourse?
Follow up with the GP or a specialist who can go back through what happened during the injury, make note of exactly what happened. The head was hit. These were the symptoms that followed, at what time frame they followed, how long they've had those symptoms, so that they can help support the diagnosis based on their medical opinion.
Great, thank you. I am an MVA concussion sufferer. Sounds like it's been about 1.5 years with PTSD. I have relationship issues from concussion challenges and PTSD. I have been approved and started working with a terrific social worker for social challenges. I also need help to resolve PTSD with a psychologist. The assessor says that's duplicate treatment. They do the same thing. Please comment.
So yes, we've heard this. As long as the psychologist and the social worker clearly delineate what they will each be working on, so that they're actually working on different things. And they should be connecting. So the social worker and the psychologist should have a discussion on who's going to be addressing what, so that there is an overlap. And then this could clearly be documented in the OCF, exactly who's going to be responsible for what components of the rehab, and also in the reports.
Great, thank you. And I just noticed in the chat, thank you very much. Harpreet Sidhu has indicated that the cost for purchasing optional benefits, so enhancing your medical benefits when you're checking those boxes on your policy, can be as low as $7.50 per month, $7.50 per month. So $90 a year. So it's definitely worth it. Okay. How can an adjuster who is not a medical expert determine if an injury is in which category? Or is which category?
Mm-hmm. Well, they have resources, I'm sure, that they follow to say, if you see in the documentation that it's a neck strain. Like there are examples that would say, okay, this person will probably need minimal rehabilitation. They can go in the minor injury guideline. If someone along the way assesses them and determines that those injuries aren't so minor, they could document that, and that could take them out of that minor injury guideline category and into the regular category where they can have access to more funding and access to the appropriate rehabilitation. I do believe that there's medical individuals that work for the insurance companies. So if adjuster has a question, there's certainly avenues where they can, probe and ask for support in determining sort of, where they think a patient might land in terms of their claim.
Great, thank you. This is just a comment, interesting from Malika, who says, thank you for the excellent webinar. And says, I wish we had a comparable insurance situation in the US. So I'm assuming that, that she is attending from there. I have found that a neuro-optometrist and a neuro-audiologist have more skills than an ENT or ophthalmologist in dealing with MTBI. They were not included in the team members mentioned. What is your experience?
So on our team, we have a neuro-ophthalmologist that's associated with our neurology specialty program, and a neuro-otologist who is our ENT physician, who has been working with brain injured patients for, I'm going to say, more than 20 years, and doing lots of research on this patient population, and very experienced. Not every patient needs a neuro-ophthalmologist. It depends on the nature of the injuries. For example, if there's a fracture around the area, they might be okay seeing an ophthalmologist. So there's different criteria for sending those folks to the different specialists based on the nature of the injury and the diagnosis.
Great, thanks very much. What is the expected timeline for insurance approval? As an example, it took 3 months for my assessor to approve a neuropsych assessment. It was 9 months before I was able to start receiving treatment, with 2 others pending. Delayed treatment exacerbates and compounds symptoms. It would seem to me that streamlining the insurance process would be cost effective. Please comment.
I agree, but they do have a time frame in which they have to reply to a submitted OCF, and I believe it's 10 days. I believe it's 2 weeks from the date of submission that they need to respond to the OCF. So I'm not sure what happened there, if an OCF was completed and submitted, or if it was a different type of request that went to the insurer.
Mm-hmm. And I guess too, after the recommendation is made, it's not always the case that the treatment there may be probably a number of factors that could affect when the treatment starts.
If they submit an OCF for treatment, it's the same that they have the 2 weeks.
Okay.
So I'm not sure what the circumstances were, if they had a hard time finding someone who could provide the treatment, or I don't know.
Okay, great. Okay, I'm just looking at this one. Is there any best way to fight the insurer that denies all non-MIG category treatment claims? After fighting and fighting, they just sent me to their fake doctor that decided that too long has passed for any recovery, so they declined to pay any further treatments. It took 2.5 years being on a wait list when I finally started some treatments that I had progress from. But basically too long had passed because of the insurer denying everything, requiring years of fighting. The COVID closures, yes, also meant a year was lost. Basically now 5 years have passed and they are off the hook according to the laws, and I really got no help. I am even still waiting for a neuropsych referral. Should I keep trying to fight to get catastrophic so there is no time limit?
That's a tough situation. So the insurance companies can opt to send folks for an independent medical examination. And that's a very thorough file review, very thorough assessment that provides recommendations. So I don't know if this individual went through an IME and what the outcome of that IME was. The only advice that I would give as a healthcare practitioner is to provide the best possible information in the reports as possible, as detailed as it can be, as I outlined with, you know, the rationale for the treatment and the reason for the assessment, and what is it gonna provide, where is it gonna take the patients in terms of recovery, as I mentioned before, return to function, return to work. So providing as much detail as possible. Some individuals have lawyers that assist them. That might be one avenue that folks might want to, you know, use to help them.
Great, thank you. And actually further along the IME, so Nadine is asking, why is my insurer asking for an independent assessment after an initial assessment was completed?
They're looking for additional information. So they want that independent examiner to comment on probably the treatment recommendations of whichever health professional this person went to.
Great, thank you. Doris is asking, my client can no longer drive, but he hasn't yet been deemed catastrophic. Can taxi or Uber be covered?
Sometimes. It depends. It just depends on the adjuster and the insurance company. And if it's a barrier for recovery, if the patient cannot attend the necessary rehabilitation, sometimes they do fund it.
Okay. At what point is it too late to seek help from Altum Health? I'm approaching 5 years post-concussion with no more funds since most was spent on OCF-18s and assessment rather than treatment. Any suggestions? Also, how do we get your info to doctors, as my experience made me feel that it was not available due to time passed post-concussion or the view that the jury's still out on concussion?
It depends on the presentation of the patient and what the patient wants to accomplish with the treatment. And do we match what the needs of that patient are at this time? So if the patient still has goals of, you know, return to some type of function, avocational, vocational activities, maybe return to school, if there are goals that we think we can help the patient with, and there might be therapies or education that they didn't receive that would have been beneficial, and it's not too late to receive that type of support from a treatment team that has lots of experience. Some of the WSIB patients that are sent our way are 2 years post. And we have a lot of success with them with this multidisciplinary approach, with consistent goals from each of the team members. Everybody knows what they're working on. We're all working towards the same goal that the patient helps establish. In terms of the referral, what would you suggest? Is it something that we could post in the chat or?
Yeah, you could. Yeah, we could put that in the chat. I don't know if Kim can.
So
maybe Kim can put that in there. Yeah.
Follow up with that.
Yeah.
You know, not every person is the same. Not every referral is the same. So we would look at each individual referral and see if there's something that we can offer with those patients. If funding is exhausted, it's tricky. We're a third-party payment stream. So we do expect the insurer to fund the relevant assessments or rehabs for the individual. So we'd have to understand the circumstances behind that as well.
Great, thank you. There was a question about a neurooptometrist. What do they do?
So a neuro-ophthalmologist?
Optometrist, sorry.
I don't know what a neuro-optometrist does. So we have a neuro-ophthalmologist on our team, and he will do a visual assessment, and he'll also look from a neurological perspective at what's going on with the eyes and the nerves in the face. I don't know the extent of each of the assessments that he does. Maybe Dr. Tartaglia, are you able to?
Yeah, neuro-ophthalmologists they're ophthalmologists who actually specialize in neurological issues related to the eyes. And some of them actually are ophthalmologists who train in neurology, and some of them are actually neurologists who train in ophthalmology. So they are different than an optometrist. And yeah, I'm not sure what a neuro-optometrist is either. We're talking about medical doctors who train in eye movements and problems related to the eyes.
Thank you.
Okay.
I knew you could answer that one.
Yeah.
Great.
But I can't answer the neuro-optometrist one. I don't know.
Okay. Thank you. Is there any chance that the 5-year time limit 5-year time limit for rehab could be extended due to the lost 2 years of pandemic?
It's a good question. I don't know what the stance is from the insurance companies with respect to that. Surely as things were shut down and individuals can access the necessary rehab that they needed in those early days, particularly, that there might be some appreciation for that and extension to their benefits for that period.
Okay, thank you. And we've just had a couple of people weigh in the chat about neurooptometrists and the fact that they are typically diagnosing things like midline shift convergence issues. And also I think they are the ones that often do the visual visual skills training for balance and other visual skills.
I know we had Dr. Rinaldi, who's a
Yes,
neuro-ophthalmologist
we
that does
did.
work with us.
Yeah.
And he probably would have had a lot to say in terms of his research and his clinical expertise and opinion on those types of treatments. So perhaps those who are interested could look at or find the recording of that, have a look.
Yeah, he spoke on that. So that you can find that on the Canadian Concussion Center's website. Okay, we have a question. I don't know if you can answer this or not. What training do adjusters have? Are they healthcare professionals?
I'm not sure.
Mm.
I know within WSIB, there's a case management team, and they're not health professionals by background, but they're working together with a nurse consultant who does have that, healthcare background. Yeah, I'm not 100% sure.
Okay, sorry. And I'm just seeing a message from Kim in the chat. So I think it was people were wanting to know the contact for Altum. Was that correct? So Kim, if you're able to put in a contact or a link perhaps to Altum's site, that would be great. Okay, so we have sort of a comment here. I think it's supposed to be IEs. IEs aren't independent assessments. The doctor has a vested financial interest in continuing their relationship with the insurer. How do we protect ourselves?
I'm not sure about that. The assessors that I know that provide independent medical examinations usually do it for both sides. So they'll do it for the insurer, but they'll also do that same work for the lawyer who's representing injured people. They usually don't just do insurance work. They really sort of have a broad approach to their assessments.
Yeah, I would tend to agree with that. I mean, I think ideally that the doctors are supposed to be going in with an objective, looking at things objectively, but okay. Sorry, I'm just flipping back in between the chat and the Q&A. So, okay, we have a comment. As a physician who has had a catastrophic motor vehicle accident and MTBI, I have found the skills of the IME MD to be extremely variable and the reports not necessarily comprehensive. What recourse is there when this is suspected?
Call it out. So have the conversation with the adjuster outlining which parts of the report are incomplete in your opinion, or do not measure up to perhaps the detail that you were expecting. So that would be our approach.
Okay, thank you. Okay, so you can find, thanks, Kim. Kim's put the link to the Canadian Concussion Center website in there, as well as the Altum Health website. Harpreet is also just added in, I think in relation to the last one, that you can, consult with a lawyer, which is often what people have to resort to. Kim has also just put the link to all of the past webinars in there as well. So if you're interested in checking out any other topics. I think that is all of the questions, unless if anyone has any other questions, please enter them now. Carmela, did you want to make any comments on anything?
No, I think, we see a lot of people who are struggling with, getting more treatments and sometimes getting misinformation about, what they should be doing in terms of, getting back to work or not getting back to work. And, I always try to encourage people, really, you want to be working towards your recovery. And we know that exercise is part of recovery, returning to work is part of recovery. And so to really, bring that or put that, really at the center of your goals. The goal is not to get the treatment. The goal is to get your life back. And so I think it's really important to work with the various practitioners that and I think when some of my patients have been at it for a while, they sometimes will focus on certain symptoms or certain disabilities, and I think that doesn't necessarily always work to their advantage. So I always urge people, be honest, really take stock of what has changed, what is getting better, what still needs to be worked on, and work with the practitioners. I often get patients who are really reluctant to take any medications to try to get better. Of course, something has happened. And so because something has happened, we sometimes have to use medications or different therapies to get the person back to baseline, to get them as close to baseline as possible. Because sometimes even as you're going back to work or back to your life, you continue to recover. And so the reluctancy to sometimes participate in that kind of therapy is a barrier for people to get back to their lives. And so, I urge people to get informed. We have a really great session by a neuropsychiatrist who talks about some of, the mental health issues that come about after concussion and are significant barriers to getting back to your life. And sometimes people are really reluctant to take anything to try to overcome that. And so Dr. Snyderman gave a talk on that, and it's, probably one of the ones in the link. And I urge people to look at that, because you don't want to be your worst enemy. You really want to be working towards your recovery. And I know it's very difficult for some patients because they talk to 10 different people and they get 10 different pieces of advice. And after a while, and when they've been at it for a while, they start to get quite confused. But I think we are very optimistic that most people who get a concussion do recover, and they recover to their baseline. So with that in mind, I think we have to, work towards that goal and do all the things we can to get to that.
That actually ties in really well. There's a couple of questions, and I think this is interesting. So one person was saying that the goal should be return to pre-injury level of functioning. Yes. And then we had someone else say, should we insist on rehab until we are returned to pre-MVA level of functioning?
Yeah, I think that, doing rehab is great. Okay. But I always tell people the same thing you apply to a medication, you have to apply to rehab. So if you have high blood pressure and I give you a blood pressure medication, your blood pressure needs to go down. And if it's not working, I hope you would come back to me and say, it's not working, you need to do something. And then we would adjust, modify, increase, add, do something, okay? Well, the same thing is about rehab. I have patients who come to me and they've been in rehab for 24 months. That is incredible to me. Like, if you should be better than new if you've been in rehab for 24 months and you have had concussion. I'm talking about concussion, not other types, right? After stroke, people stay in rehab for prolonged periods. I'm talking about from a concussion perspective. So that makes me wonder how it is that somebody is in rehab for that long. And I ask them to question, really their improvement trajectory. And is this rehab actually getting them back to baseline? Because rehab is your time, is your energy, and is money, right? So you need to assess that. And if after a few sessions, for different people, it's different, obviously. It's very individualized. But after a few sessions, whatever that number is, if you don't feel like you're making incremental gains, and if you're not getting to your goal, then you need to reassess that. You need to reassess that therapist. You need to reassess the goals. You need to continuously reassess why you're engaged in this. And I often tell people, even if they're not back to their baseline, they should try to get back to work. And so sometimes they'll start off on these graduated return to work and they still have symptoms. And then we work at fixing the symptoms, because I think it's really terrible for people to stay off work for years. And then we finally get them to a point where they feel like, oh yeah, I have no more symptoms, I'm pretty good. And then we put them in a super stressful situation under bright lights and they have to concentrate all day and there's some concussion symptoms return. Well, it's not realistic to do that. So no, I do not think you have to be back to baseline before you can go back to work, at least on a, modified with some help. But people should aim to get back to work as soon as they can.
Mm-hmm. Yeah, I would really agree with that, because I think, and I this sort of reminds me when I was working on an outpatient neuro rehab program at Toronto Rehab, where we generally had people that had more severe injuries than concussion. But one of the first things they're told when they come in, they have a limited duration of rehab. And these individuals had, a max of 3 months. And the idea of the rehab was really to equip people with tools and strategies that they can then take away. So I see that as well with concussion. I think, as you say, if you've been doing something for 2 years and going for appointments, you do have to start to wonder, if there's something else going on. So Nadine asks, how does a recovery look after a second concussion or suspected concussion at a young age of 12? Maybe Carmela, you can.
So I'm not sure I understood. So the person had a second concussion and they were 12 years old and they were already struggling from
Sounded like it. That's all we have. Yeah, it's just, okay. Yeah. Nadine, if you want to add anything else in there.
Yeah. So, it's always more difficult when somebody has a new concussion, over top of the recovery of the previous concussion. You can imagine sometimes their symptoms are amplified. The gains that they had made from their first concussions, obviously, they feel that there's a setback, but still most people will recover. So, I have cases where a person had a concussion, they had, post-traumatic headaches, post-traumatic mood problems, sleep problems, and, they're like, 6-7 months out, things had started to improve. We were actually thinking of, modifying the treatments, like getting them off some of the medications, getting them back to, some work, and then all of a sudden they get a second concussion. And of course, then there's a setback. And so then we, restart the therapies and just still optimistic that they will recover. But, it's going to be more prolonged. And so, we have to go back to the drawing board for certain things. But at the end of the day, we do not think that they'll end up in a chronic situation because they've had 2 concussions.
Okay,
Yeah.
Great, thank you. Yeah, she just added that it happened as a child.
Mm.
And maybe just one final one from Karen. This is to Josie, and I don't know, Josie, it's not something that you're necessarily treating, but asking what you suggest for sound sensitivity after MTBI. So I'm wondering at Altum if that's something that you often see.
We do. So sensitivity to light and sensitivity to noise. Our approach is gradual exposure. During the treatment with the healthcare professional can give them sort of tips and tricks along the way to sort of work through those symptoms. And, you know, as Dr. Tartaglia said, they don't have to go sort of full speed when they're, you know, returning to certain types of activities. Really sort of just a gradual approach to just things around the home. And then, you know, thinking about work and that gradual graded return to work plan for work, where you can have clinicians or the clinical team support you through it and sort of remind you of strategies of, you know, what to use, you know, what to do when you're feeling sort of overwhelmed with those sensitivities. Carmela, do you have anything to add?
Yeah, I mean, I think that's a great question, and we see that a lot. And I usually tell people, so the first context I see that in is people who have lots of headaches. And so they're, even as their headaches get better, they're always on the verge of getting a headache. And, you know, because when you think of like, what is sound sensitivity? You know, it's like this pain that people feel sometimes, or this discomfort. And so we make sure that the post-traumatic headache is well treated, because I have to tell you that once that goes away, most of my patients no longer have sound or light sensitivity. And light and sound sensitivity are part of headache, even if they don't come about from concussion. And then, you know, as you mentioned, you know, slowly exposing yourself. I find sometimes people get quite anxious when they have light and sound sensitivity that persists. And then just the anxiety about the discomfort they're going to feel with the sound just amplifies the problem. We know that anxiety can make pain worse. So I always tell people that, you know, they should be, whether it's some cognitive behavioral therapy for their anxiety or treatment for their anxiety, but it's really important to treat anxiety.
Great, thank you. Carmela, we definitely have, this one is for you. I've had 6 concussions over my lifetime and haven't recovered after 4 years. I'm 61 years old. What is the likelihood I will descend to dementia?
Yeah, I think, you know, that's a great question. And, you know, I think one of the risk factors for neurodegenerative disease is concussion and is repeated concussion. And so we always, you know, alert people to be careful about that. But we know that there's people, like I see former professional contact sports athletes, and some of them have had many concussions and they're in their 80s and they are not demented. So it's not a one-to-one relationship. There are modifying or mitigating factors where some people seem to be more resilient to concussion, others seem to be more vulnerable. And I think there's always, you know, you always have to remember there's things you can do to promote your brain health. We know there is lots of evidence that aerobic exercise can delay neurodegenerative disease. So that includes Alzheimer's disease, that includes Parkinson's. We know that even if you have these illnesses, aerobic exercise can slow them down. We know that lifelong learning can slow down these diseases, can delay their onset. Socialization. So we have things that are within our control to try to keep things going as slowly as possible, even if we have a degenerative process. And I would just say that you're not destined for degeneration just because you've had, you know, 6 concussions in your life.
Great, thank you. Okay, I think just given the time, we've got one last question, and you could probably, this person can probably benefit too from looking back at some of our former videos, but they say, I understand the importance of returning to work as soon as possible. But what would the approach be if your job is to sit in front of a computer and that makes your concussion symptoms worse, I guess? How should someone manage that, especially coordinating with your employer?
If Josie, I mean, I can just start quickly that, we suggest a graduated return to work. And so, you would be going back, not sitting in front of a computer for 8 hours a day, but maybe, an hour or two. And I usually suggest people can start that at their home, in their homes, right? Just kind of expose yourself, and make sure you treat all the other symptoms that could be exacerbating your screen sensitivity. So including headache. Yeah, and I'll let Josie.
That's exactly it. So we would do that exposure in the clinic because they are with us several days a week for treatment. And it would be, for example, if it was a teacher and they wanted to return to work, one activity that they could do with the clinician is go on the computer and create a lesson plan. So it would just be small activities that reflect what they need to do at work to make it meaningful. And to also demonstrate to the patient that they can, in fact, do some of the components of their job. They may need to have modifications. So the clinician can help develop a return to work plan week by week on how to gradually increase the duties and the hours and the days over weeks while they're in treatment, so that they can have that support while they're returning to work. And as they return to work more, maybe they need less of that support and less of the rehab. So that would be our approach.
Great, thank you very much. And thank you to Dr. Tartaglia for the answer to the last question regarding dementia from that person. And one final one, is there a gene, Carmela, that determines resiliency from concussion?
That's a fantastic question, and we are looking for it because we definitely know that there's some people who seem to be quite resilient, not just to concussion, to a lot of things in life, and other people more vulnerable. And we'd like to figure out what that is. So, we have an active research program looking at that.
Great, thank you so much. Thank you, Josie, for the great presentation, and to both of you for the great answers to a lot of really interesting and great questions tonight as well. Just as always, we will be forwarding a very short 2-minute survey. We would love it if you could complete that and provide your feedback, any suggestions. And our next session will be in 2 weeks, Tuesday, April 12th. And we're going to be discussing prevention of subsequent concussions with Stephanie Cowell from Parachute Canada and Dr. Firas Al-Rawi. Thanks so much and have a good evening.
Thank you all for coming.
Thank you.
Bye-bye.